So thank you for joining today for the CareDx Symposium. I'm Robert Woodward with CareDx. I'm the Chief Scientific Officer. I'm going to lead you through a few slides about CareDx products before we get to the featured speakers. You're probably most of you aware of CareDx and our history of providing innovative solutions for post-transplant care, all the way from the first gene expression profiling use for transplant care, donor-derived cell-free DNA first in heart and in kidney and then in heart and lung, and even more recently our use of donor-derived cell-free DNA and gene expression profiling in managing xenotransplant patients. But you may not be aware of the breadth of offerings we have across the patient journey, from all the way from logistics support, from Medigo and TX Access waitlist management, through quality management, through XynQAPI, all the way to patient management with a variety of products, including AlloHome, which is remote patient monitoring. I think we've heard some about remote patient monitoring at this meeting. CareDx has a solution for that. But what we're going to be talking about today is the innovative technologies, that is the use of two together, multi-modality, where you're using two different tools that have different mechanisms, looking at immune activation, looking at graft injury, to have more power to correlate with rejection and reduce the need for biopsies. And then integration of numerous critical factors, including the donor-derived cell-free DNA AlloSure test, to give an assessment of graft health in kidney transplant. So first, Dr. Karen Cush from Stanford will speak on the multimodality and real-world examples of its use in heart transplantation. And then second, Dr. Sapna Shah will talk about the use of AlloView, the AI-derived algorithm in kidney transplantation. So I'll turn it over to Dr. Cush.
Thank you so much, Robert. It's really a pleasure to be here today. So I'd like to talk about molecular assays to detect graft injury. And I think that this is a really powerful approach that we've adopted over the past few years, because as you know, by the time injury or rejection is picked up on biopsy, it's often very late in the process. Immune activation has already occurred, the horse is already out of the barn. And what these molecular tests offer us the ability to do is pick up very early signs of immune activation and graft injury, and hopefully start treatment earlier before we even start to see graft damage on biopsy. Because by the time you see cell death on biopsy, often you already have irreversible graft injury. So I think this is a really powerful approach that we now have to detect immune activation and graft injury early. So there's many different molecular assays that have been developed or are currently in development, and I believe that these are very complementary. And this is a review article that we published last year looking at different molecular assays for the diagnosis of complications after heart transplantation. And as you know, they all look at different aspects of the alloimmune response and different types of complications. So for example, we have donor-derived cell-free DNA and gene expression profiling to survey for acute rejection. We have some blood-based protein biomarkers that can look at graft dysfunction. We have different biomarkers to look for development of chronic rejection or cardiac allograft vasculopathy. And so the beauty is these different molecular assays are looking at different aspects of the alloimmune response, different complications, and put together, they can provide more information than just one assay in and of itself. And so for today's talk, I'd like to focus on the fact that molecular assays look at various aspects of the alloimmune response and can therefore provide more data when used simultaneously. So we know, for example, that donor-derived cell-free DNA, or in this case, the AlloSure assay, and gene expression profiling, or the AlloMap assay, can both be used to screen for the development of acute cellular rejection after heart transplantation. And this was an analysis of the Dior study, which was a prospective registry study of AlloMap and AlloSure that were used in screening heart transplant patients for development of acute cellular rejection. And what we found was that over half of patients had assays that were both negative. Both AlloMap and AlloSure were below the threshold. About a quarter of patients had a high AlloMap and a low AlloSure. Another 11% had a low AlloMap and a high AlloSure, and 6% of patients had both tests above the threshold. Now, what we've learned is that in patients who have both assays below the threshold, both negative assays, the likelihood of rejection is very low. For patients with a high AlloMap and high AlloSure, they have the highest positive predictive value for development of acute rejection. So you can be pretty confident that this is a patient who needs a biopsy to determine whether rejection is present. And then on the intermediate levels, we have patients with a high AlloMap and a low AlloSure, where you may want to think about other causes of immune activation like CMV infection. And then a low AlloMap and a high AlloSure, you may look at other causes of graft injury like antibody-mediated rejection or development of de novo DSAs. And so we asked the question, can we actually reduce our use of protocol biopsies by using these non-invasive tests? And can using more than one test at a time help further reduce the need for biopsies? And so this is a study that we did in our cohort at Stanford. So from 2015 to 2017, we only had gene expression profiling for non-invasive surveillance. So if someone had an abnormal AlloMap test, they'd go on to have a biopsy. And then starting in 2018, we also had AlloSure. So we could now add the donor-derived cell-free DNA test and base the performance of biopsies on both tests combined. And so we actually looked at how many surveillance biopsies we ended up doing. And we found that when we combined both the AlloMap and AlloSure assays, we were performing way fewer biopsies than patients who only had gene expression profiling. And so this shows the ability of multimodality testing to really further reduce the number of biopsies that we do. And we also showed that when both assays were above the threshold, the likelihood of acute rejection was quite high. Here, 2 out of 10 biopsies had acute rejection, but when they're both below the threshold, the likelihood of acute rejection is very low. And in this case, only 1 patient out of 348 actually had acute rejection. And so what this tells us is that we're able to really get away from doing surveillance protocol-based biopsies with the use of multimodality non-invasive surveillance. And this is supported by the new ISHLT guidelines for the care of heart transplant recipients, which state that routine testing and clinic visits are crucial for the long-term success of heart transplantation. And the purpose of these follow-up visits is to monitor for rejection and screen for adverse events. And one of the guidelines, Class 1 level of evidence B, is that follow-up visits to monitor for rejection may include non-invasive rejection monitoring using gene expression profiling and donor-derived cell-free DNA. And certainly now, about 90%, if not more, of heart transplant centers across the US have adopted these techniques for their routine patient surveillance. So we know that within the first year after transplant, surveillance is mainly used to monitor for acute cellular rejection. But the chance of detecting ACR just on a routine surveillance biopsy is really low because overall the incidence of ACR is pretty low. And so the chance of detecting cellular rejection on a surveillance biopsy is only about 2 to 3%. And so why are we doing all these biopsies? Well, the primary value of a surveillance molecular test is its ability to detect patients who are at high risk who actually do have justification for having a biopsy. And this is called the positive likelihood ratio, which is defined as the sensitivity over 1 minus specificity. And what we've shown is that if you have a high AlloMap alone, the likelihood ratio is 1.5. A high AlloSure alone has a likelihood ratio of 2.7, but when you combine the two assays, the likelihood ratio is significantly increased. It goes up to 14. So really, the utility of these tests to then prompt a follow-up biopsy is much greater when you combine the two assays together compared to either one alone. And so this is really the approach that we've adopted at Stanford for our routine surveillance. And this is our protocol that applies to all of our heart transplants, regardless of whether they're high risk or low risk of rejection, sensitized or not. What we do is we do 2 surveillance biopsies within the first month after transplant. And starting at 1 month, we do donor-derived cell-free DNA testing. And starting at 2 months, we do the 2 assays together, the cell-free DNA and the gene expression assay. And then we continue these non-invasive surveillance approaches for the first 2 years post-transplant, and then we stop our routine surveillance. And so we now have significantly reduced the number of biopsies we do, and the biopsies that we do order are better informed and better targeted towards the patients who really need them. And so that's why I think that multimodality is really where the field is heading. Molecular testing allows for the very sensitive interrogation of immune activation and graft injury. It's a very early marker, and using more than 1 assay at a time can provide complementary information, different aspects of the alloimmune response, different post-transplant complications, and it's really allowed us to reduce the number of invasive biopsies that we do. And so stay tuned, there's going to be a lot more data coming out of the SHORE registry. Those analyses are ongoing now. Some of that data will be presented at ISHLT this year, but a lot more data will be presented shortly on a very large real-world population of heart transplant patients surveyed with multimodality testing. So thank you very much.
And now we'll move on to the presentation by Dr. Shah.
Good morning, everyone. So my name is Sapna Shah. I'm a transplant nephrologist at the University of Southern California, and today I'll be talking to you about the utility of AlloView in clinical practice. So in the current era of medicine, there's an ever-increasing arsenal of data that we use for clinical decision-making, right? We have lab and urine value trends, imaging studies, DSA, donor and recipient characteristics, non-HLA-mediated DSA, donor-derived cell-free DNA, gene expression assays, historical biopsy data, immunosuppression agents. Really, there's a lot. And all of this data is important and extremely valuable and allows us to practice personalized medicine, but can occasionally leave you feeling like you have information overload and perhaps you're juggling which one of these parameters is most important. And what should I do about this? And leave you with the sensation that perhaps you've overlooked something. So this whole conference that we're at today is looking at tools, technologies, innovations, algorithms that we can use to support our clinical decision-making, particularly, hopefully, on those tough calls that we have to make. So I want to spend the next few minutes today talking to you about our transplant center's experience with the use of AlloView, which streamlines multiple clinical parameters into a simple objective output. This, in turn, has the potential to facilitate more standardized clinical decision-making in the future. So what is AlloView? AlloView is a predictive model put forward by the Paris Transplant Group and CareDx that provides an integrated view of the various factors associated with rejection. The initial cohort was done in 2 French studies. It's since been validated in the US and the EU with a total of 2,500 patients. The investigators assessed various determinants for kidney allograft rejection as shown on the slide. So you can see donor and recipient characteristics, baseline transplant characteristics, functional parameters, parameters at the time of evaluation, and immunologic parameters, and performed a uni and multivariate analysis, that regression to assess the various determinants of kidney allograft rejection. So you can see on the slide the ones that these factors that they found, kidney graft instability, previous rejection episodes, the presence of anti-HLA DSA, donor-derived cell-free DNA, EGFR, and proteinuria were found to be the most correlated with rejection. The machine learning algorithm currently in development is assessing numerous other variables that may be important, but these are the inputs that have been found and are currently used in the calculation of the AlloView score. So this is the AlloView score. These are the inputs, the composite inputs that are put in to give you an output. And the AlloView score is anywhere from 0 to 100. So how is AlloView used in clinical practice? So at our center at the University of Southern California, we've been using this application to retrospectively study the utility of the algorithm. So for me, it's easiest to discuss the technology by presenting a case. So I'll start. My first patient was a 63-year-old male with ESRD secondary to presumed hypertensive nephrosclerosis who received a deceased donor kidney transplant. He was a 5-antigen mismatch to the kidney, cross-match negative, with CPRA 0, and received Simulect for induction. He was maintained on triple immunosuppression therapy, which is our protocol, but had DGF with suboptimal graft function at 3 months. So you can see the value of the trend of his lab values. By 3 months, he had sustained suboptimal graft function with an eGFR of about 30 mLs per minute. He had moderate proteinuria of 0.3 to 0.5. He had an AlloSure tech at 2 months and 2.5 months. And you can see by 2.5 months, the AlloSure was starting to trend up, and he really had sustained suboptimal graft function, which is why we decided to pursue biopsy at this point. In retrospect, we went back and we calculated the AlloView score to see, what would that correlate and how well does it correlate with the biopsy findings that we saw. And for this patient, the AlloView score, the integrated view of rejection risk, was found to be 18.2%. So the biopsy was then performed for evaluation of suboptimal graft function. It was a good sample, but it found no evidence of T-cell-mediated rejection or antibody-mediated rejection. It did show likely donor-derived changes of moderate IFTA, or hypertensive arteriosclerosis, and some tubular injury. So as a result, likely suboptimal graft function was donor-derived, and as a result, we decided to change our immunosuppression management, and we switched him to belatacept. Retrospectively, when we went back and we looked at, what are those AlloView scores at 2 months, 2.5, 3 months, and it's interesting that you can see that, they had fairly low AlloView scores, what I would consider to be a low AlloView score at 2 months, 2.5 months, and 3 months. Despite having an elevated creatinine and moderate range of proteinuria. And so it's interesting to see that, the AlloView scores were low even with those things. So in summary, for this patient, a biopsy was done for evaluation of suboptimal graft function. He had normal cell-free DNA and a low AlloView score. My take, in this patient, maybe a biopsy could have been avoided. Maybe it wasn't needed. And perhaps in the future, I'd feel more comfortable changing to belatacept based on these findings alone without the need for a biopsy. Another patient. So this one is a 46-year-old female who had ESRD, secondary congenital kidney disease. She received a deceased donor kidney transplant. She was a 5-antigen mismatch to this donor, cross-match negative, CPRA 0, received thymoglobulin for induction. She was also had no DSA at the time of transplant, was maintained on triple immunosuppressive therapy, but unfortunately she developed BK viruria within 1 month post-transplant, BK viremia within 3 months post-transplant, right? Something that we see commonly amongst our patients. So as a result of the BK viruria and then viremia, her maintenance immunosuppression was reduced, and unfortunately for her, we were having trouble getting approval for IVIG as well. So if you look at the value of her trends, you can see that, her creatinine was fairly stable for the first 6 months post-transplant. There wasn't much fluctuation. Her creatinine had fluctuated. She natered at 0.8, and her range was 0.8 to 1 with low levels of proteinuria. But within 1 month post-transplant, she developed BK viruria, and within 3 months post-transplant, she developed sustained BK viremia. Our center for our protocol at the time was to do AlloSure at 1 month, 3 months, and 6 months. So you can see at 1 month and 3 months, she had very low AlloSure scores, but by the time she was 6 months, she had an AlloView score of 2.9. As a result of the BK viremia, she had gradual reduction in her immunosuppression, first with reduction in her antipentabolite, and then second with reduction in her tacrolimus level. When we retrospectively went back to calculate an AlloView score for this patient, the integrated view of rejection risk was found to be 62.9%, which I would consider fairly high. A biopsy was performed because we were concerned about the risk of rejection, but also because of the concern of perhaps this is BK nephropathy. So in this patient, she actually had ACR1A without any evidence of AMR, and notably her SV40 stain was negative. So the diagnosis for her, acute cellular rejection 1A. She was treated with Solumedrol and IVIG while she was hospitalized. But in summary, cases where there's simultaneous BK and concern for rejection really are clinically challenging. So for her, a biopsy was performed for clinical suspicion of BK nephropathy and or rejection. But what I think is that, in hindsight, a more frequent monitoring of her AlloSure and her AlloView score may have led to an earlier decision to biopsy. And this led us to update our protocols for our patients with BK viremia to check AlloSure and AlloView scores more frequently. So, my take, whether or not we like it, I think medicine is changing. In the coming years, I anticipate more tools, more technology, more AI advancements to help with our clinical decision making. With this technology, I think there's plenty of unanswered questions. Is there truly an AlloView score that I would consider safe? What do I do with those AlloView scores that are in the middle? And can this technology really help decrease the need for biopsy in the future? I do think that one day in the not so different future, we'll be using AlloView more in our clinical practice, and I hope that it will decrease our need for biopsy in the future. And with that, I thank you all for your time, and if you have any questions.